Question 1. Operational review demonstrates that a 45-year-old patient with a diagnosis of treatment-resistant major depressive disorder and comorbid generalized anxiety disorder has failed to achieve remission on 2 adequate trials of selective serotonin reuptake inhibitors, SRI, and 1 trial of a serotonin norepinephrine reuptake inhibitor, SNRI. The patient reports persistent anhedonia, low energy, and significant worry, impacting their daily functioning. The physician is considering pharmacological augmentation strategies. Which of the following represents the most appropriate next step in pharmacological management? Option A. Addition of a short-acting benzodiazepine for anxiety symptoms. Option B. Augmentation with an atypical antipsychotic. Option C. Augmentation with lithium. Option D. Initiation of a second antidepressant from a different class, such as a tricyclic antidepressant, TCA. Correct answer is C. Augmentation with lithium. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient with a complex psychiatric condition, specifically treatment-resistant depression with comorbid anxiety, requires a careful and individualized pharmacological approach. The challenge lies in balancing efficacy, tolerability, and potential drug interactions, especially when considering augmentation strategies. The physician must navigate evidence-based guidelines while also accounting for the patient's unique history and response to prior treatments. Correct approach analysis. The correct approach involves a systematic and evidence-based augmentation strategy for treatment-resistant depression, incorporating a medication known to have efficacy in this context and considering the patient's comorbid anxiety. Lithium augmentation is a well-established, evidence-based strategy for treatment-resistant depression, supported by numerous clinical trials and meta-analyses. Its mechanism of action, which involves modulating neurotransmitter systems and neurotrophic factors, can be beneficial when standard antidepressant monotherapy has failed. Furthermore, lithium has demonstrated efficacy in managing comorbid anxiety symptoms, making it a suitable choice for this patient. This approach aligns with current psychiatric guidelines and best practices for managing complex mood disorders. Incorrect approach is analysis. Initiating a second antidepressant from a different class without a clear rationale for augmentation or considering the patient's prior non-response is a less optimal strategy. While switching antidepressants is a common step, in treatment-resistant depression, augmentation is often preferred over simply switching, especially if the patient has failed multiple monotherapies. This approach risks further side effects without necessarily addressing the underlying resistance. Adding a benzodiazepine for anxiety without addressing the primary depressive disorder or considering its long-term risks is ethically problematic. Benzodiazepines are generally not recommended for long-term management of anxiety in the context of depression due to risks of dependence, tolerance, and potential for worsening depressive symptoms. This approach treats a symptom without addressing the core illness and carries significant risks. Prescribing an antipsychotic as an augmentation agent without a clear indication for psychosis or severe mood dysregulation is not the first-line augmentation strategy for treatment-resistant depression. While atypical antipsychotics can be used for augmentation in some cases, they carry a higher risk profile for metabolic side effects and other adverse events, and their use should be guided by specific clinical indications beyond simple treatment resistance. Professional reasoning. When faced with treatment-resistant depression and comorbid anxiety, the professional decision-making process should involve a thorough review of the patient's treatment history, including previous medications, dosages, duration of treatment, and response. This should be followed by an assessment of current symptoms and functional impairment. Consultation of current evidence-based guidelines for treatment-resistant depression and comorbid conditions is crucial. The physician should then consider augmentation strategies that have demonstrated efficacy and a favorable risk-benefit profile for the individual patient, prioritizing interventions that address both the depression and anxiety components of the illness. Open communication with the patient about treatment options, potential benefits, and risks is paramount. Question 2. The efficiency study reveals that a patient with bipolar disorder who has been stable on lithium for 2 years with minimal mood swings reports persistent difficulties with concentration and social engagement, impacting their work performance. Which of the following represents the most appropriate next step in managing this patient's care? Option A. Increase the dosage of lithium to aggressively eliminate any remaining subtle mood fluctuations, as even minor variations can be detrimental. Option B. Discontinue lithium therapy immediately, as the patient has demonstrated sustained stability and may no longer require mood stabilization. Option C. Introduce a novel antipsychotic medication to address the reported concentration and social engagement issues without further evaluation of the current regimen. Option D. Conduct a comprehensive assessment of cognitive function and social functioning and discuss the patient's goals for improved quality of life and work performance before considering adjustments to the current treatment plan. The correct answer is D. Conduct a comprehensive assessment of cognitive function and social functioning and discuss the patient's goals for improved quality of life and work performance before considering adjustments to the current treatment plan. Explanation. Scenario analysis. This scenario presents a common challenge in psychiatric practice, optimizing treatment for a patient with bipolar disorder who has achieved initial stability but continues to experience residual symptoms impacting daily functioning. The professional challenge lies in balancing the need for continued symptom management with the potential for medication side effects, patient adherence, and the desire to improve overall quality of life. A nuanced approach is required, moving beyond simple symptom reduction to a more holistic assessment of functional recovery. Correct approach analysis. The correct approach emphasizes a comprehensive evaluation of the patient's current state, including not only mood symptoms, but also cognitive function, social engagement, and overall quality of life. This aligns with best practices in bipolar disorder management, which advocate for a personalized, multidimensional approach. The American Board of Psychiatry and Neurology, APN guidelines, while not explicitly detailing specific treatment algorithms for every scenario, underscore the importance of patient-centered care, thorough assessment, and evidence-based interventions. This approach prioritizes shared decision-making, ensuring the patient's goals and preferences are integrated into the treatment plan. It also reflects the understanding that functional recovery is a key outcome in managing chronic mental health conditions like bipolar disorder, and that intervention should aim to facilitate this. Incorrect approaches analysis. One incorrect approach focuses solely on adjusting medication dosage to eliminate any remaining subtle mood fluctuations. This fails to acknowledge that complete absence of any mood variation might not be achievable or desirable, and could lead to overmedication with increased risk of side effects and reduced patient adherence. It overlooks the broader impact of bipolar disorder on functioning beyond mood states. Another incorrect approach suggests discontinuing all mood-stabilizing medication due to the patient's current stability, assuming a complete remission. This is a significant regulatory and ethical failure, as it disregards the chronic nature of bipolar disorder and the high risk of relapse without maintenance treatment. APN standards emphasize the importance of long-term management strategies for conditions like bipolar disorder to prevent recurrence and maintain stability. A third incorrect approach involves introducing a new, experimental medication without a clear indication or a thorough assessment of the current treatment's limitations. This deviates from evidence-based practice and could expose the patient to unnecessary risks and costs without a strong rationale. It bypasses the systematic evaluation of existing treatments and the patient-specific needs, which is a cornerstone of responsible medical practice. Professional reasoning. Professionals should approach such cases by first conducting a thorough reassessment of the patient's current status, utilizing validated assessment tools for mood, cognition, and functioning. This should be followed by a collaborative discussion with the patient about their treatment goals, concerns, and perceived impact of residual symptoms on their life. Based on this comprehensive understanding, a tailored treatment plan should be developed, which may involve optimizing current medication, considering adjunctive therapies, pharmacological or non-pharmacological, or exploring lifestyle interventions. The decision-making process must be guided by evidence-based guidelines, patient safety, and the principles of shared decision-making, ensuring all interventions are justified and clearly communicated. Question 3. Strategic planning requires a comprehensive approach to managing a patient with treatment-resistant depression who has failed to achieve remission on an SRI and subsequent augmentation with lithium. The patient's mood remains significantly impaired, impacting their daily functioning. What is the most appropriate next step in the management plan? Option A. Initiate a trial of a different class of antidepressant, such as an SNRI, or consider a novel agent like vortioxetine, after a thorough review of the patient's medication history and adherence. Option B. Discontinue all psychotropic medications and advise the patient to focus solely on lifestyle modifications and supportive therapy. Option C. Immediately refer the patient for experimental neuromodulation techniques, such as deep brain stimulation, given the refractory nature of their symptoms. Option D. Increase the dosage of the current SRI to the maximum tolerated level, despite previous augmentation attempts. The correct answer is A. Initiate a trial of a different class of antidepressant, such as an SNRI, or consider a novel agent like vortioxetine, after a thorough review of the patient's medication history and adherence. Explanation. This scenario presents a professionally challenging situation due to the complex and often refractory nature of treatment-resistant depression, TRD. The challenge lies in navigating multiple therapeutic options, considering patient-specific factors, and adhering to evidence-based guidelines while ensuring patient safety and efficacy. Careful judgment is required to avoid premature escalation of treatment or the adoption of unproven modalities. The correct approach represents best professional practice by systematically evaluating and implementing evidence-based augmentation strategies for TRD. This aligns with the American Board of Psychiatry and Neurology's emphasis on adhering to established clinical guidelines and utilizing treatments with demonstrated efficacy and safety profiles. Specifically, considering a trial of a different class of antidepressant, such as a serotonin-norepinephrine reuptake inhibitor SNRI, or a novel agent like vortioxetine, after inadequate response to an SRI and augmentation with lithium, reflects a structured, evidence-informed progression. This approach prioritizes patient well-being by minimizing risks associated with unproven treatments and maximizing the likelihood of achieving remission. An incorrect approach involving immediate referral for experimental neuromodulation without a thorough review of pharmacological augmentation options fails to adhere to the principle of stepwise, evidence-based treatment. This could be considered a failure to provide appropriate care as per established guidelines, potentially exposing the patient to risks without exhausting more conventional, well-researched interventions. Another incorrect approach, such as discontinuing all psychotropic medications due to perceived treatment failure, is ethically problematic as it abandons the patient and neglects the physician's duty to provide ongoing care and explore alternative therapeutic avenues. This constitutes a failure to manage a complex psychiatric condition responsibly. A further incorrect approach, such as solely relying on adjunctive psychotherapy without re-evaluating pharmacological strategies, overlooks the established multimodal treatment paradigms for TRD, which often necessitate a combination of pharmacotherapy and psychotherapy. Professional decision-making in such situations requires a systematic approach. First, confirming the diagnosis of TRD and ruling out contributing factors, e.g., substance use, medical comorbidities, poor adherence. Second, reviewing current and past treatments, including dosages and duration, to ensure adequate trials. Third, considering evidence-based augmentation or switching strategies, prioritizing those with robust clinical trial data. Fourth, engaging the patient in shared decision-making, discussing risks, benefits, and alternatives. Finally, ongoing monitoring and reassessment are crucial to adjust the treatment plan as needed. Question 4. The performance metrics show a significant increase in patients presenting with severe, treatment-resistant depression who have failed multiple monotherapy and combination pharmacotherapy trials, as well as psychotherapy interventions. Considering the available evidence and established clinical guidelines for managing such complex cases, which of the following treatment modalities, when considered as a next step, best aligns with the principles of evidence-based practice and patient well-being? Option A. Continued escalation of existing pharmacotherapy dosages. Option B. Augmentation with a novel investigational psychotropic agent. Option C. Electroconvulsive therapy ECT. Option D. A brief adjunctive course of a different psychotherapy modality. The correct answer is C. Electroconvulsive therapy ECT. Explanation. This scenario presents a common clinical challenge in managing treatment-resistant depression, requiring a nuanced understanding of evidence-based practices and patient-specific factors within the framework of American Board of Psychiatry and Neurology, APN guidelines. The professional challenge lies in balancing the efficacy of different treatment modalities with their respective risk profiles, patient preferences, and the need for continuous monitoring and adjustment of care. Careful judgment is required to select the most appropriate intervention that maximizes therapeutic benefit while minimizing potential harm and adhering to ethical standards of patient care. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment and a stepwise escalation of evidence-based treatments. Electroconvulsive therapy (ECT) is a highly effective treatment for severe, treatment-resistant depression, particularly when rapid symptom improvement is needed or when other modalities have failed. Its use is supported by robust clinical evidence and is considered a standard of care in such situations, aligning with APBAN emphasis on evidence-based medicine and patient safety. The decision to consider ECT after failure of pharmacotherapy and psychotherapy reflects a judicious application of treatment guidelines. An incorrect approach would be to solely rely on increasing the dosage of existing pharmacotherapy without considering alternative classes or augmentation strategies, especially if the patient has already failed multiple trials. This could be considered a failure to adhere to best practices in managing treatment-resistant depression, potentially leading to prolonged suffering and increased risk of adverse outcomes. Ethically, it may represent a failure to adequately explore all reasonable treatment options. Another incorrect approach would be to immediately recommend a novel or experimental treatment without a thorough trial of established, evidence-based modalities like ECT, particularly if the patient's condition is severe. This could be seen as deviating from established clinical pathways and potentially exposing the patient to unproven risks without exhausting more reliable options. It might also raise concerns about informed consent if the experimental nature and lack of robust evidence are not clearly communicated. A further incorrect approach would be to dismiss psychotherapy as ineffective after a limited trial, especially if it was not delivered with sufficient intensity or duration, or if the specific modality was not well matched to the patient's needs. Psychotherapy, when appropriately applied, can be a crucial component of depression management, even in severe cases, and its premature abandonment could be a missed opportunity for synergistic treatment effects with pharmacotherapy or other interventions. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's diagnostic clarity, symptom severity, previous treatment history, including duration, dosage, and adherence, comorbidities, and patient preferences. This should be followed by a discussion of evidence-based treatment options, their relative risks and benefits, and a collaborative decision-making process with the patient. Regular reassessment of treatment response and side effects is critical, with a willingness to adjust the treatment plan as needed, escalating to more intensive interventions when indicated by clinical guidelines and patient presentation. Question 5. Comparative studies suggest that when a patient with schizophrenia fails to achieve adequate symptom control on a trial of a second-generation antipsychotic, which of the following represents the most appropriate next step in pharmacological management? Option A. Switching to a different second-generation antipsychotic with a distinct receptor binding profile or considering clozapine. Option B. Adding a second antipsychotic agent to the current regimen. Option C. Discontinuing all antipsychotic medication and focusing solely on non-pharmacological interventions. Option D. Increasing the dose of the current second-generation antipsychotic, assuming it was not at the maximum recommended dose. The correct answer is A. Switching to a different second-generation antipsychotic with a distinct receptor binding profile or considering clozapine. Explanation. Scenario analysis. This scenario presents a common clinical challenge in managing patients with schizophrenia and other psychotic disorders, determining the most appropriate pharmacological intervention when initial treatment with a second-generation antipsychotic (SGA) has proven ineffective. The challenge lies in balancing efficacy, tolerability, and patient safety, while adhering to evidence-based guidelines and regulatory recommendations. Clinicians must navigate potential side effects, patient adherence, and the nuances of different drug classes and their mechanisms of action. The decision-making process requires a thorough understanding of the available treatment options, their risk-benefit profiles, and the specific needs and characteristics of the individual patient. Correct approach analysis. The correct approach involves a systematic and evidence-based escalation of treatment. Given the failure of the initial SGA, switching to a different SGA with a distinct receptor binding profile or considering clozapine, a third-generation antipsychotic with a unique efficacy profile for treatment-resistant schizophrenia, are considered best practices. Clozapine, in particular, is recognized as the gold standard for treatment-resistant schizophrenia due to its superior efficacy in reducing positive, negative, and effective symptoms, as well as its lower risk of extrapyramidal side effects compared to some older antipsychotics. The decision to consider clozapine is often guided by established clinical guidelines, such as those from the American Psychiatric Association, APA, which recommend its use after inadequate response to at least 2 different antipsychotics. This approach prioritizes patient well-being by seeking a more effective treatment, while acknowledging the need for careful monitoring due to clozapine's potential side effects, such as agranulocytosis, requiring strict adherence to monitoring protocols. Incorrect approaches analysis, continuing the same SGA at a higher dose without a clear rationale for improved efficacy, especially if the initial dose was within the therapeutic range and side effects were not dose-limiting, represents a failure to adhere to evidence-based treatment algorithms. This approach risks exposing the patient to unnecessary side effects without a reasonable expectation of benefit and deviates from the principle of optimizing treatment by exploring alternative pharmacological agents. Adding a second antipsychotic to the non-responsive SGA is generally not recommended as a first-line strategy for treatment resistance. While combination therapy can be considered in specific, refractory cases under expert supervision, it is not the standard of care after a single failed trial. This approach increases the risk of polypharmacy, drug interactions, and additive side effects without a strong evidence base for improved outcomes in this initial stage of treatment resistance. It also fails to address the core issue of the initial agent's lack of efficacy. Discontinuing all antipsychotic medication and relying solely on non-pharmacological interventions, while important adjuncts, is not appropriate when a patient has a diagnosis of schizophrenia and has not responded to an initial antipsychotic trial. Psychotic disorders, by definition, often require pharmacological management to control symptoms and prevent relapse. Abandoning medication without a clear clinical indication or a comprehensive plan for alternative evidence-based management would be a significant ethical and professional lapse, potentially leading to symptom exacerbation and functional decline. Professional reasoning. Professionals should approach treatment resistance by first reviewing the diagnosis and ensuring adherence to the initial medication. If adherence is confirmed, and the diagnosis is stable, the next step is to consider a switch to an agent with a different pharmacological profile. Guidelines from professional bodies like the APA provide a framework for this decision-making. The choice between another SGA or clozapine depends on the severity and nature of the treatment resistance, the patient's prior response to different drug classes, and the presence of comorbidities. A thorough risk-benefit assessment, including a discussion of potential side effects and monitoring requirements with the patient, is crucial. If clozapine is considered, strict adherence to its monitoring requirements, e.g., regular blood counts, is paramount to ensure patient safety and comply with regulatory mandates. Question 6. Assessment of a patient's potential for developing major depressive disorder, considering a family history of the illness, recent significant life stressors, and a history of substance use, requires a nuanced understanding of which of the following epidemiological principles. Option A. The prevalence of comorbid anxiety disorders in the general population. Option B. The typical age of onset for bipolar disorder. Option C. The efficacy of specific psychotherapeutic interventions for mild depressive symptoms. Option D. The interplay of genetic predisposition, environmental triggers, and individual vulnerability in the etiology of depression. The correct answer is D. The interplay of genetic predisposition, environmental triggers, and individual vulnerability in the etiology of depression. Explanation. Scenario analysis. This scenario presents a common challenge in psychiatric practice, identifying and managing potential risk factors for a prevalent mental health condition. The professional challenge lies in accurately assessing the likelihood of developing the condition based on a constellation of individual and environmental factors, while respecting patient privacy and avoiding premature diagnostic labeling. The physician must synthesize information from various sources and apply epidemiological knowledge to guide preventative strategies or early intervention. Correct approach analysis. The correct approach involves a comprehensive risk assessment that considers established epidemiological data and known risk factors for the condition in question. This aligns with best professional practice by enabling a personalized and evidence-based approach to patient care. It allows for targeted interventions, patient education, and proactive management, ultimately aiming to improve patient outcomes and potentially prevent or mitigate the severity of the illness. This approach is ethically sound as it prioritizes patient well-being and informed decision-making. Incorrect approach is analysis. One incorrect approach involves dismissing the patient's concerns or family history due to a lack of personal experience with the condition. This fails to acknowledge the robust epidemiological evidence and established risk factors, potentially leading to delayed diagnosis and treatment. It represents a failure in professional diligence and a disregard for established medical knowledge. Another incorrect approach is to immediately initiate aggressive pharmacological treatment based solely on the presence of a few risk factors, without a thorough assessment of the individual's overall clinical presentation and the probability of developing the condition. This can lead to unnecessary side effects, patient distress, and a misallocation of resources, violating the principle of judicious medical intervention. A further incorrect approach is to overemphasize a single risk factor while ignoring other significant contributors. This oversimplification can lead to an inaccurate risk assessment and a failure to implement a comprehensive management plan. It demonstrates a lack of nuanced understanding of multifactorial disease etiology. Professional reasoning. Professionals should approach risk assessment by first identifying the specific condition of concern and recalling its known epidemiological profile and established risk factors. This involves reviewing current literature and guidelines. Next, they should gather relevant patient-specific information, including personal history, family history, lifestyle, and environmental exposures. The gathered information should then be systematically evaluated against the known risk factors, considering their relative contributions and interactions. This allows for a nuanced estimation of the individual's risk. Based on this assessment, appropriate next steps can be determined, which may include further diagnostic evaluation, patient education, lifestyle modifications, or close monitoring. This systematic process ensures that decisions are evidence-based, patient-centered, and ethically sound. Question 7. When evaluating a patient participating in a psychosocial rehabilitation program who expresses a desire to reduce their engagement with structured group activities, citing a preference for more independent pursuit of personal goals, what is the most appropriate initial clinical response according to the principles guiding psychiatric practice and rehabilitation? Option A. Inform the patient that adherence to the established program structure is non-negotiable for successful rehabilitation and that their request cannot be accommodated. Option B. Refer the patient to a different, less structured rehabilitation program without discussing their current concerns or exploring potential adaptations within the existing program. Option C. Schedule a meeting with the patient to explore their concerns, discuss the rationale behind the current program structure, and collaboratively explore potential modifications to the rehabilitation plan that balance their preferences with evidence-based recovery principles. Option D. Immediately adjust the patient's rehabilitation plan to significantly reduce structured activities, assuming their expressed preference indicates a better path forward without further discussion. The correct answer is C. Schedule a meeting with the patient to explore their concerns, discuss the rationale behind the current program structure, and collaboratively explore potential modifications to the rehabilitation plan that balance their preferences with evidence-based recovery principles. Explanation. This scenario presents a professional challenge in psychosocial rehabilitation by requiring a clinician to balance patient autonomy with the need for evidence-based, structured support, all within the framework of the American Board of Psychiatry and Neurology's APN guidelines, which implicitly emphasize patient-centered care and adherence to established treatment modalities. The core difficulty lies in determining the appropriate level of intervention when a patient expresses a desire for less structured engagement in a rehabilitation program, while the clinician believes more structured participation is crucial for achieving recovery goals. The correct approach represents best professional practice because it prioritizes a collaborative, patient-centered strategy. This involves open communication with the patient to understand their concerns and preferences, exploring the rationale behind their desire for less structure, and jointly developing a modified rehabilitation plan that respects their autonomy, while still incorporating evidence-based elements proven effective in psychosocial rehabilitation. This aligns with ethical principles of beneficence, acting in the patient's best interest, and respect for persons, acknowledging their right to self-determination. It also implicitly adheres to APN commitment to high-quality patient care, which necessitates adapting treatment to individual needs and fostering patient engagement. An incorrect approach that focuses solely on enforcing the existing structured program without further discussion fails to acknowledge the patient's expressed needs and preferences, potentially leading to disengagement and undermining the therapeutic alliance. This could be seen as a failure in patient-centered care, a core tenet of modern psychiatric practice. Another incorrect approach that immediately dismisses the patient's request and insists on the original plan without exploring alternatives disregards the principle of shared decision-making and may be perceived as paternalistic, potentially damaging the therapeutic relationship and hindering progress. A third incorrect approach that unilaterally alters the plan without patient input or a clear rationale, even if seemingly accommodating, bypasses essential communication and collaboration, violating ethical standards of transparency and respect for patient autonomy. The professional decision-making process for similar situations should involve a systematic approach. First, actively listen to and validate the patient's concerns. Second, explore the underlying reasons for their preferences. Third, educate the patient about the benefits of different levels of structure in rehabilitation and the potential consequences of reduced engagement. Fourth, collaboratively problem-solve to identify mutually agreeable modifications to the rehabilitation plan. And fifth, document the discussion, the agreed-upon plan, and the rationale for any changes, ensuring ongoing monitoring of the patient's progress and satisfaction. Question 8. Stakeholder feedback indicates a patient with a recent diagnosis of moderate major depressive disorder presence with persistent low mood, anhedonia, and significant functional impairment in their work and social life. The patient expresses a strong desire to engage in talk therapy, but is also open to medication. Considering current best practices for managing moderate depression, which of the following treatment approaches would be most appropriate? Option A. Initiate a trial of a selective serotonin reuptake inhibitor, SRI, in conjunction with a referral for cognitive behavioral therapy, CBT. Option B. Focus solely on lifestyle modifications, such as increased exercise and improved sleep hygiene, without pharmacological or psychotherapeutic intervention. Option C. Prescribe a benzodiazepine for immediate symptom relief and advise the patient to wait for therapy to become available. Option D. Recommend a trial of electroconvulsive therapy, ECT, as a first-line treatment due to the severity of functional impairment. The correct answer is A. Initiate a trial of a selective serotonin reuptake inhibitor, SRI, in conjunction with a referral for cognitive behavioral therapy, CBT. Explanation. This scenario presents a common challenge in psychiatric practice, balancing evidence-based treatment with patient preferences and potential contraindications. The professional challenge lies in accurately assessing the patient's current symptom severity, functional impairment, and readiness for different therapeutic modalities, while also considering the potential for adverse effects and drug interactions. Careful judgment is required to select the most appropriate and effective treatment plan that aligns with best practices and patient well-being. The correct approach represents best professional practice because it prioritizes a comprehensive assessment to guide treatment selection. Cognitive behavioral therapy, CBT, is a well-established, evidence-based psychotherapy for managing depressive symptoms. Combining it with a selective serotonin reuptake inhibitor, SRI, is a recognized and often highly effective first-line treatment strategy for moderate to severe depression, offering synergistic benefits. This approach is supported by numerous clinical guidelines and research, emphasizing a multimodal treatment strategy when indicated. It respects the patient's desire for therapy while also addressing the biological component of depression with medication, chosen for its favorable side effect profile and efficacy in this context. An incorrect approach would be to solely recommend medication without exploring psychotherapy options. This fails to acknowledge the robust evidence supporting psychotherapy as a primary or adjunctive treatment for depression, and may overlook patient preferences for non-pharmacological interventions. Ethically, it could be seen as not fully exploring all appropriate treatment avenues. Another incorrect approach would be to recommend a medication with a higher risk of significant side effects or drug interactions without a clear clinical rationale or prior failure of less risky options. This would violate the principle of beneficence and non-maleficence, as it exposes the patient to unnecessary risks. Furthermore, recommending a treatment that is not evidence-based for the patient's specific presentation, or one that is contraindicated due to their medical history, would be a significant professional and ethical failure. The professional reasoning process should involve a thorough diagnostic evaluation, including assessment of symptom severity, duration, impact on functioning, and presence of comorbid conditions. This should be followed by a discussion of evidence-based treatment options, including their respective benefits, risks, and patient preferences. Shared decision-making is crucial, empowering the patient to participate actively in their treatment plan. Regular monitoring and reassessment of treatment efficacy and tolerability are essential to adjust the plan as needed. Question 9. Process analysis reveals a patient presenting with persistent feelings of being wronged by colleagues, a tendency to interpret neutral or friendly remarks as hostile, and a reluctance to confide in others due to a fear of exploitation. The patient also describes odd, tangential speech patterns and occasional perceptual distortions, such as feeling a presence when alone, but denies significant social withdrawal or a desire for close relationships. Which diagnostic approach best aligns with a comprehensive evaluation of potential cluster of personality disorders? Option A. Prioritize the patient's lack of desire for close relationships and social detachment as the primary diagnostic indicators, suggesting schizoid personality disorder, and attribute the other symptoms to situational stress. Option B. Conduct a thorough assessment of the pervasive nature of suspiciousness, the presence of cognitive and perceptual distortions, and the impact on social and occupational functioning, considering the differential diagnostic criteria for paranoid, schizoid, and schizotypal personality disorders. Option C. Immediately diagnose the patient with a cluster of personality disorder based on the initial presentation of distrust and odd speech, and initiate supportive therapy without further detailed diagnostic exploration. Option D. Focus on the patient's expressed beliefs about others' malevolence and reluctance to confide, leading to a primary consideration of paranoid personality disorder, while noting the tangential speech as a secondary observation. The correct answer is D. Focus on the patient's expressed beliefs about others' malevolence and reluctance to confide, leading to a primary consideration of paranoid personality disorder, while noting the tangential speech as a secondary observation. Explanation. This scenario presents a common challenge in psychiatric practice, differentiating between the pervasive distrust and suspicion characteristic of paranoid personality disorder, and the social detachment and emotional coldness seen in schizoid personality disorder, while also considering the peculiar thoughts and behaviors associated with schizotypal personality disorder. The professional challenge lies in accurately assessing the patient's internal experiences and interpersonal functioning, without imposing personal biases or misinterpreting idiosyncratic behaviors as necessarily indicative of a specific disorder. Careful judgment is required to avoid premature labeling and to ensure that the diagnostic formulation is based on a comprehensive understanding of the patient's presentation across various contexts. The correct approach represents best professional practice because it prioritizes a thorough, multifaceted diagnostic evaluation. This involves gathering information from multiple sources, including collateral information if available and appropriate, and utilizing standardized assessment tools. It emphasizes understanding the pervasiveness and impact of the patient's traits on their functioning and relationships, which is crucial for distinguishing between the cluster of disorders. This aligns with the ethical obligation to provide accurate diagnoses and appropriate treatment, grounded in evidence-based practice and diagnostic criteria. An incorrect approach that focuses solely on the patient's expressed beliefs about others' malevolence, without exploring the underlying social anxiety or cognitive distortions, would likely lead to an overdiagnosis of paranoid personality disorder and missed nuances of schizotypal personality disorder. This fails to meet the standard of care by not conducting a sufficiently comprehensive assessment. Another incorrect approach that emphasizes the patient's lack of desire for social interaction, while overlooking their peculiar beliefs and odd mannerisms, would likely result in a misdiagnosis of schizoid personality disorder, failing to capture the cognitive and perceptual distortions characteristic of schizotypal personality disorder. This represents a failure to adhere to diagnostic specificity, an incorrect approach that relies on anecdotal observations or stereotypes about individuals with cluster of traits, rather than a systematic diagnostic process, is ethically unsound and professionally negligent. This approach lacks objectivity and can lead to stigmatization and inappropriate treatment. The professional reasoning process should involve a systematic approach to differential diagnosis. This includes 1. Obtaining a detailed history of present illness and past psychiatric history. 2. Assessing current mental status, including thought content, perception, affect, and behavior. 3. Exploring interpersonal relationships and social functioning. 4. Considering the impact of symptoms on occupational and overall functioning. 5. Utilizing diagnostic criteria from the DSM-5-TR for cluster disorders. And 6. Considering collateral information when available and appropriate to gain a more complete picture of the patient's presentation. This structured approach ensures that all relevant diagnostic possibilities are considered and that the final diagnosis is well supported by the evidence. Question 10. Upon reviewing the chart of a 45-year-old patient with bipolar I disorder, currently maintained on lamotrigine monotherapy for bipolar depression, who reports persistent episodes of hypomania and irritability despite good adherence and a stable dose for 6 months, what is the most appropriate next step in management? Option A. Augment lamotrigine with an atypical antipsychotic with established mood-stabilizing properties. Option B. Add a benzodiazepine for acute management of irritability episodes. Option C. Immediately discontinue lamotrigine and initiate valproic acid monotherapy. Option D. Recommend intensive psychotherapy without further medication adjustments. Correct answer is A. Augment lamotrigine with an atypical antipsychotic with established mood-stabilizing properties. Explanation. This scenario presents a common clinical challenge in managing bipolar disorder, optimizing treatment for a patient experiencing persistent mood lability despite initial monotherapy. The core difficulty lies in balancing efficacy with tolerability, considering the patient's specific symptom profile and potential for adverse effects. The American Board of Psychiatry and Neurology, APN, emphasizes evidence-based practice and patient-centered care, requiring clinicians to navigate complex treatment algorithms and individualize therapeutic decisions. The correct approach involves a systematic, evidence-based escalation of treatment, prioritizing adjunctive therapies with established efficacy for mood stabilization and a favorable safety profile in the context of the patient's comorbidities. This aligns with APN guidelines that advocate for a stepwise approach to treatment-resistant mood disorders, often involving augmentation strategies. Specifically, adding a second mood stabilizer or an atypical antipsychotic with mood-stabilizing properties is a well-supported strategy for achieving better symptom control. This approach prioritizes patient safety by considering potential drug interactions and side effects, and it reflects a commitment to achieving optimal functional outcomes. An incorrect approach would be to abruptly discontinue the current mood stabilizer without adequate justification or a clear plan for immediate replacement. This could lead to rapid mood decompensation and withdrawal symptoms, posing a significant risk to patient safety and violating the ethical principle of non-maleficence. Another incorrect approach would be to introduce a medication with a high risk of adverse effects or limited evidence for augmenting mood stabilization in this specific context, without a thorough risk-benefit analysis. This demonstrates a failure to adhere to evidence-based practice and could lead to iatrogenic harm. Furthermore, solely relying on non-pharmacological interventions without addressing the persistent pharmacological need for mood stabilization would be insufficient and potentially neglectful, failing to meet the patient's immediate clinical needs. Professionals should approach such situations by first conducting a comprehensive reassessment of the patient's current presentation, including symptom severity, adherence, and any contributing factors. This should be followed by a review of evidence-based treatment guidelines for treatment-resistant bipolar disorder, a shared decision-making process with the patient, discussing available options, their potential benefits, risks, and alternatives is crucial. The decision-making process should be iterative, with regular monitoring and adjustment of the treatment plan based on the patient's response and tolerability. Question 11. During the evaluation of a patient presenting with a history of repeated interpersonal conflicts, a pervasive sense of being misunderstood and mistreated by others, and a strong conviction that they are exceptionally talented but unrecognized, which of the following diagnostic approaches best aligns with the rigorous standards of the American Board of Psychiatry and Neurology for assessing Cluster B personality disorders? Option A. Focus primarily on the patient's dramatic and attention-seeking presentation, attributing their difficulties to a need for external validation and a lack of emotional control, and initiate treatment aimed at managing immediate emotional distress. Option B. Immediately explore the possibility of malingering given the patient's strong convictions and potential for secondary gain, and focus the assessment on identifying inconsistencies in their account to rule out deceptive behavior. Option C. Conduct a comprehensive diagnostic interview and review of psychiatric history, systematically assessing for the presence and pervasiveness of core features of antisocial, borderline, histrionic, and narcissistic personality disorders, while also considering differential diagnoses and potential co-occurring conditions. Option D. Prioritize a thorough exploration of the patient's narrative of external injustices and perceived slights, focusing on validating their feelings of being wrong to build rapport, and then consider a diagnosis that best fits this narrative. The correct answer is D. Prioritize a thorough exploration of the patient's narrative of external injustices and perceived slights, focusing on validating their feelings of being wrong to build rapport, and then consider a diagnosis that best fits this narrative. Explanation. This scenario presents a significant professional challenge due to the inherent complexities of diagnosing and managing cluster B personality disorders, particularly when overlapping features are present. The clinician must navigate the diagnostic criteria meticulously while also considering the potential for malingering or secondary gain, which can complicate the assessment. The patient's presentation, with its emphasis on perceived injustices and a desire for external validation, necessitates a careful balance between empathetic engagement and objective evaluation, adhering strictly to the diagnostic guidelines of the American Board of Psychiatry and Neurology (APBN). The correct approach involves a comprehensive diagnostic evaluation that systematically assesses for the core features of each cluster B personality disorder, while also considering differential diagnoses and potential co-occurring conditions. This includes utilizing structured diagnostic interviews, collateral information when available and appropriate, and a thorough review of the patient's history. The focus remains on identifying enduring patterns of inner experience and behavior that deviate markedly from the expectations of the individual's culture, are pervasive and inflexible, have an onset in adolescence or early adulthood, are stable over time, and lead to distress or impairment. This aligns with APBN emphasis on evidence-based diagnostic practices and ethical patient care, ensuring that interventions are tailored to the specific diagnostic profile and not influenced by the patient's persuasive narrative alone. An incorrect approach would be to immediately accept the patient's self-assessment and focus solely on the narrative of being wronged, without a systematic diagnostic process. This could lead to misdiagnosis, inappropriate treatment planning, and a failure to address the underlying personality pathology. For instance, focusing exclusively on the patient's claims of narcissistic injury, without exploring the pervasive patterns of grandiosity, entitlement, and lack of empathy characteristic of narcissistic personality disorder, would be a diagnostic failure. Similarly, attributing all interpersonal difficulties solely to the actions of others, without exploring the patient's role in creating or exacerbating these conflicts, neglect the core features of antisocial personality disorder, such as disregard for and violation of the rights of others. Overemphasizing the patient's dramatic presentation and need for attention without a thorough assessment of emotional dysregulation, unstable relationships, and identity disturbance would be a failure to adequately consider borderline personality disorder. The professional decision-making process for similar situations should involve a structured, multifaceted approach. First, engage in active, empathetic listening to understand the patient's subjective experience. Second, systematically apply the diagnostic criteria for all relevant personality disorders, using validated assessment tools and considering differential diagnoses. Third, seek collateral information if ethically permissible and clinically indicated to obtain a more objective perspective. Fourth, maintain professional objectivity, recognizing that patients with personality disorders may present with persuasive narratives that can influence the clinician. Finally, document the diagnostic process thoroughly, including the rationale for inclusion or exclusion of specific diagnostic criteria and the consideration of alternative explanations. Question 12. The evaluation methodology shows a patient with a chronic, progressive neurological condition who has consistently expressed a strong desire to remain in their home environment, despite increasing functional limitations and a recent fall. The patient's family is concerned about safety and is advocating for placement in a specialized assisted living facility. The physician's long-term management strategy must consider the patient's expressed wishes, their evolving capacity, and the family's concerns. Which of the following represents the most ethically and professionally sound long-term management strategy? Option A. Focus solely on medical interventions to manage the neurological condition, leaving all decisions regarding living arrangements and support to the family and the patient without active physician guidance or involvement. Option B. Implement a comprehensive in-home support plan, including assistive technologies, regular occupational and physical therapy, and increased caregiver support, while continuing to monitor the patient's capacity and safety, and engaging in ongoing dialogue with both the patient and family about evolving needs and preferences. Option C. Defer to the patient's wishes to remain at home without further assessment of their current safety risks or capacity, assuming their desire to stay overrides any potential dangers. Option D. Prioritize the family's concerns and initiate the process for placement in an assisted living facility, explaining to the patient that this is necessary for their safety, even if it contradicts their stated preference to remain at home. The correct answer is B. Implement a comprehensive in-home support plan, including assistive technologies, regular occupational and physical therapy, and increased caregiver support, while continuing to monitor the patient's capacity and safety, and engaging in ongoing dialogue with both the patient and family about evolving needs and preferences. Explanation. This scenario presents a professional challenge due to the inherent tension between a patient's expressed wishes and the clinician's assessment of their long-term well-being, particularly when cognitive impairment is a factor. The physician must balance patient autonomy with beneficence, ensuring the patient's safety and quality of life are prioritized while respecting their right to make decisions. The APBIN ethical guidelines and standards of practice emphasize the importance of comprehensive assessment, shared decision-making, and the physician's responsibility to act in the patient's best interest, especially when capacity is in question. The correct approach involves a thorough, ongoing assessment of the patient's capacity to make informed decisions regarding their long-term care plan. This includes exploring the patient's understanding of their condition, treatment options, and potential consequences, as well as their values and preferences. When capacity is compromised, the physician must engage with surrogate decision-makers, adhering to established legal and ethical frameworks for substituted judgment or best interests. This collaborative and iterative process, documented meticulously, upholds patient dignity and ensures care aligns with their evolving needs and wishes, as supported by APBIN principles on patient-centered care and ethical conduct. An incorrect approach would be to unilaterally impose a treatment plan without a robust assessment of capacity or meaningful engagement with the patient and their surrogates. This disregards the ethical imperative of patient autonomy and can lead to care that is misaligned with the patient's values or best interests. Another incorrect approach is to dismiss the patient's stated preferences entirely, even if their capacity is questionable, without exploring the underlying reasons for those preferences or attempting to find a compromise that respects their autonomy as much as possible. This can erode trust and lead to patient dissatisfaction and non-adherence. Failing to involve appropriate legal or ethical resources when significant disagreements arise, or when capacity is severely impaired, also represents a failure to adhere to professional standards and protect the patient's rights. Professionals should approach such situations by first conducting a comprehensive assessment of the patient's cognitive status and decision-making capacity. This should be followed by open and empathetic communication with the patient, exploring their understanding, values, and goals. If capacity is impaired, the process must involve identifying and engaging with appropriate surrogate decision-makers, ensuring they understand their role and the patient's known wishes or best interests. Documentation of all assessments, discussions, and decisions is paramount. When faced with complex ethical dilemmas or significant disagreements, seeking consultation from ethics committees, legal counsel, or senior colleagues is a crucial step in professional decision-making. Question 13. Consider a scenario where a 3-year-old child is brought to your clinic by concerned parents who report the child doesn't interact much and stares off into space. The parents are anxious about developmental delays, What is the most appropriate initial approach to assess for autism spectrum disorder ASD? Option A. Immediately reassure the parents that these behaviors are common in toddlers and suggest they monitor the child for another 6 months before further evaluation. Option B. Recommend a trial of intensive behavioral therapy for social skills without a formal diagnostic assessment to see if the behaviors improve. Option C. Focus solely on the reported staring off into space and inquire about seizure activity, as this may indicate a neurological issue rather than ASD. Option D. Conduct a comprehensive diagnostic evaluation, including a detailed developmental history, direct observation of the child's social interaction and communication, and the administration of a validated ASD screening tool. The correct answer is D. Conduct a comprehensive diagnostic evaluation, including a detailed developmental history, direct observation of the child's social interaction and communication, and the administration of a validated ASD screening tool. Explanation. This scenario presents a common challenge in child psychiatry, differentiating between early signs of autism spectrum disorder (ASD) and other developmental or behavioral conditions, particularly when parental concerns are vague. The professional's responsibility is to conduct a comprehensive, evidence-based assessment that considers multiple domains of development and behavior, rather than relying on a single symptom or parental impression. The American Board of Psychiatry and Neurology, APN, emphasizes the importance of accurate diagnosis and appropriate intervention planning based on current scientific understanding and ethical practice. The correct approach represents best professional practice by adhering to established diagnostic criteria and utilizing a multimodal assessment strategy. This includes gathering detailed developmental history, direct observation of the child's behavior, and standardized diagnostic tools. Such a thorough evaluation ensures that the diagnosis is accurate and that interventions are tailored to the individual child's needs, aligning with APN commitment to high standards of patient care and professional competence. An incorrect approach that focuses solely on a single symptom, such as limited eye contact, without further investigation, fails to meet diagnostic thresholds for ASD and risks misdiagnosis. This overlooks the complexity of ASD, which requires a pattern of persistent deficits in social communication and social interaction, as well as restricted, repetitive patterns of behavior, interests, or activities. Relying on anecdotal evidence or parental anxiety alone, without objective assessment, is ethically unsound and professionally negligent, as it can lead to inappropriate or delayed treatment. Another incorrect approach might be to immediately recommend behavioral therapy without a formal diagnostic evaluation, which bypasses the critical step of establishing a diagnosis and understanding the specific nature and severity of the child's challenges. This is not only inefficient, but also potentially harmful if the underlying issues are not ASD or require a different therapeutic modality. Professionals should employ a systematic decision-making process that begins with a thorough intake and history, followed by direct observation and standardized assessments. This iterative process allows for the integration of information from various sources to arrive at the most accurate diagnosis. When faced with ambiguous presentations, it is crucial to consider differential diagnoses and to involve parents or caregivers as active participants in the assessment process, ensuring transparency and shared understanding. Question 14. The review process indicates a need to evaluate a clinician's diagnostic process for a patient presenting with recurrent depressive episodes and occasional periods of increased energy, talkativeness, and decreased need for sleep, which are not severe enough to cause significant functional impairment or require hospitalization. The clinician is considering a diagnosis of bipolar Roman II disorder. Which of the following diagnostic considerations best reflects the appropriate application of diagnostic criteria for differentiating between bipolar I, bipolar Roman II, and cyclothymia in this context? Option A. The clinician should focus primarily on the severity of the depressive episodes to determine the appropriate bipolar subtype. Option B. Cyclothymia is characterized by at least 2 years of numerous periods with hypomanic symptoms that do not meet criteria for a hypomanic episode, and numerous periods with depressive symptoms that do not meet criteria for a major depressive episode. Option C. A diagnosis of bipolar I disorder requires at least one manic episode, which can be preceded or followed by hypomanic or major depressive episodes. Option D. the presence of at least one major depressive episode and at least one hypomanic episode, with the hypomanic episodes not meeting criteria for a manic episode, is the defining characteristic of bipolar Roman II disorder. Correct answer is D. The presence of at least one major depressive episode and at least one hypomanic episode, with the hypomanic episodes not meeting criteria for a manic episode, is the defining characteristic of bipolar Roman II disorder. Explanation. The review process indicates a need to assess the clinician's diagnostic acumen regarding bipolar spectrum disorders, specifically differentiating between bipolar I, bipolar Roman II, and cyclothymia. This scenario is professionally challenging because the presentation of mood disorders can be nuanced, with overlapping symptoms and varying degrees of functional impairment. Accurate diagnosis is paramount for effective treatment planning, patient safety, and appropriate utilization of healthcare resources. Misdiagnosis can lead to suboptimal or even harmful interventions, prolonged suffering, and increased risk of adverse outcomes. The correct approach involves a comprehensive diagnostic evaluation that meticulously considers the presence, duration, and severity of manic, hypomanic, and depressive episodes, as well as subthreshold mood disturbances. This aligns with the diagnostic criteria outlined in the DSM-5, which is the standard for psychiatric diagnosis in the United States, and therefore the governing framework for the American Board of Psychiatry and Neurology. A thorough history, including collateral information when available, is essential to capture the full spectrum of the patient's mood experiences and their impact on functioning. An incorrect approach would be to make a diagnosis based solely on the presence of depressive symptoms without adequately assessing for a history of hypomanic or manic episodes. This fails to adhere to the core diagnostic requirement for bipolar disorders, which necessitates the presence of elevated or irritable mood states. Another incorrect approach would be to label a patient with cyclothymia based on transient mood fluctuations that do not meet the full criteria for hypomanic or depressive episodes, or if the duration of symptoms is insufficient. This overlooks the specific diagnostic thresholds for cyclothymia, which requires a period of at least 2 years, 1 year in children and adolescents, with numerous periods of hypomanic symptoms that do not meet criteria for a hypomanic episode and numerous periods of depressive symptoms that do not meet criteria for a major depressive episode. Finally, an incorrect approach would be to overemphasize the severity of depressive symptoms to the exclusion of any history of elevated mood, potentially leading to a diagnosis of unipolar depression when a bipolar disorder is present. This diagnostic error is critical as treatments for unipolar depression can sometimes exacerbate manic or hypomanic symptoms in individuals with bipolar disorder. Professional decision-making in such cases requires a systematic approach. First, gather detailed symptom history, focusing on temporal patterns and specific symptom clusters. Second, differentiate between manic, hypomanic, and depressive episodes based on established diagnostic criteria. Third, assess the duration and frequency of mood disturbances to distinguish between bipolar I, bipolar Roman II, and cyclothymia. Fourth, consider functional impairment associated with these mood states. Finally, integrate all gathered information to arrive at the most accurate diagnosis, recognizing that diagnostic refinement may be necessary over time. Question 15. Which approach would be most appropriate when a patient with a known history of a neurodegenerative disorder expresses a desire to discontinue a medication that the treating psychiatrist believes is crucial for managing their symptoms and preventing functional decline, given the potential neurobiological underpinnings of the patient's decision-making process? Option A. Proceed with discontinuing the medication without further discussion, assuming the patient's request is a manifestation of their underlying neurobiological condition and therefore not a reflection of their true wishes. Option B. Immediately discontinue the medication as requested by the patient to respect their autonomy, regardless of the potential neurobiological factors that might impair their judgment. Option C. Persuade the patient to continue the medication by emphasizing the severity of their illness and the potential negative outcomes of discontinuation, without a formal assessment of their capacity. Option D. Conduct a thorough assessment of the patient's decision-making capacity, exploring their understanding of the medication's benefits and risks, the consequences of discontinuation, and the neurobiological factors that may be influencing their judgment, while engaging in shared decision-making. The correct answer is D. Conduct a thorough assessment of the patient's decision-making capacity, exploring their understanding of the medication's benefits and risks, the consequences of discontinuation, and the neurobiological factors that may be influencing their judgment, while engaging in shared decision-making. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the clinician's assessment of potential neurobiological underpinnings that might impair the patient's capacity to make fully informed decisions. The clinician must navigate the ethical imperative to respect patient autonomy, while also upholding the duty of beneficence and non-maleficence, ensuring the patient's safety and well-being. The neurobiological underpinnings of the patient's condition, such as potential executive dysfunction or altered reward processing, complicate the assessment of decision-making capacity, requiring a nuanced and evidence-based approach. The correct approach represents best professional practice by prioritizing a comprehensive, multifaceted assessment of the patient's decision-making capacity. This involves not only evaluating the patient's understanding of their condition and treatment options, but also exploring the neurobiological factors that might be influencing their judgment. Engaging in shared decision-making, involving the patient in the process as much as possible, and seeking collateral information when appropriate, are all crucial elements. This approach aligns with the ethical principles of autonomy, beneficence, and justice, and adheres to the guidelines of the American Board of Psychiatry and Neurology, which emphasize patient-centered care and thorough clinical evaluation. An incorrect approach that involves unilaterally overriding the patient's wishes based solely on the clinician's suspicion of neurobiological impairment is ethically and professionally unacceptable. This failure to engage in a thorough assessment of capacity and to involve the patient in shared decision-making violates the principle of autonomy. Another incorrect approach, that of proceeding with treatment without adequately addressing the patient's concerns or exploring the neurobiological factors influencing their decision, neglects the duty of beneficence and can lead to iatrogenic harm or patient dissatisfaction. A third incorrect approach, which involves prematurely deeming the patient incapacitated without sufficient evidence or a structured assessment process, can be paternalistic and undermine the therapeutic alliance. Professionals should employ a structured decision-making process that begins with a presumption of capacity. When concerns arise, a systematic evaluation of understanding, appreciation, reasoning, and expressing a choice should be conducted, taking into account any identified neurobiological factors. This evaluation should be collaborative, involving the patient, and, where appropriate, their designated surrogate decision-maker or trusted family members. The goal is to support the patient's autonomy to the greatest extent possible, ensuring that any limitations on their decision-making are clearly identified, justified, and addressed through appropriate interventions or support. Question 16. The risk matrix shows a patient with a severe, debilitating specific phobia of needles, trypanophobia, who requires regular intramuscular injections for a chronic psychiatric condition. The patient expresses extreme distress and refusal to undergo injections, stating it is the worst fear they have ever experienced. The psychiatrist must decide on the best course of action to ensure the patient receives necessary treatment while respecting their autonomy and minimizing harm. Option A. Implement a gradual exposure therapy protocol, incorporating cognitive behavioral techniques and exploring alternative medication formulations that do not require injections, while maintaining open communication and collaborative decision-making with the patient. Option B. Proceed with administering the injections under sedation, as this is the most efficient way to ensure the patient receives their medication promptly. Option C. Administer the injections without further discussion, as the patient's underlying condition requires immediate and consistent treatment, and their phobia is a secondary concern. Option D. Inform the patient that their phobia is interfering with essential treatment, and that if they do not comply with injections, their treatment will be discontinued. The correct answer is A. Implement a gradual exposure therapy protocol, incorporating cognitive behavioral techniques and exploring alternative medication formulations that do not require injections, while maintaining open communication and collaborative decision-making with the patient. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the clinician's ethical and professional obligation to provide evidence-based care. The patient's fear of needles, trypanophobia, a specific phobia, is significantly impacting their ability to engage with necessary medical interventions, creating a dilemma for the psychiatrist. The psychiatrist must balance respecting patient autonomy with ensuring the patient receives appropriate treatment for their underlying condition, which may require injections. The American Board of Psychiatry and Neurology, APN, guidelines emphasize patient-centered care, informed consent, and the use of evidence-based treatments. The correct approach involves a multifaceted strategy that prioritizes desensitization and alternative treatment modalities before resorting to potentially coercive measures. This aligns with best professional practice by acknowledging the patient's phobia as a legitimate clinical concern that requires therapeutic intervention. It upholds the principle of beneficence by seeking to alleviate the patient's suffering and improve their health outcomes, while also respecting their autonomy by attempting to address the phobia directly. The use of gradual exposure therapy, cognitive behavioral techniques, and exploring alternative medication formulations are all evidence-based strategies for managing specific phobias, particularly in a medical context. This approach demonstrates a commitment to ethical practice by seeking the least restrictive and most therapeutic means to achieve treatment goals. An incorrect approach would be to dismiss the patient's phobia as a minor inconvenience and proceed with forced injections. This would be a significant ethical and regulatory failure, violating the principle of patient autonomy and informed consent. It would also be considered battery, as it involves unwanted physical contact. Furthermore, it fails to adhere to the APN emphasis on evidence-based treatments, as forcing injections is unlikely to be effective in the long term and may exacerbate the patient's anxiety and distrust. Another incorrect approach would be to immediately discontinue all necessary treatment due to the phobia without exploring any alternatives. This would violate the principle of non-maleficence, as it could lead to a worsening of the patient's underlying condition, and it fails to uphold the professional responsibility to find solutions for patient care challenges. A third incorrect approach would be to prescribe sedatives without addressing the phobia itself. While sedation might temporarily facilitate an injection, it does not treat the underlying phobia and can lead to dependence or other adverse effects, failing to provide comprehensive and sustainable care. Professional decision-making in such situations requires a systematic process. First, thoroughly assess the severity and impact of the specific phobia. Second, engage in open and empathetic communication with the patient to understand their fears and explore their willingness to engage in treatment for the phobia. Third, consult evidence-based guidelines for managing specific phobias in medical settings, including desensitization techniques and pharmacological options. Fourth, explore all available alternative treatment modalities that do not involve needles. Fifth, if injections remain unavoidable, develop a detailed, gradual exposure plan in collaboration with the patient, potentially involving a mental health professional specializing in phobias. Finally, document all discussions, assessments, and treatment plans meticulously. Question 17. Benchmark analysis indicates that a 45-year-old male patient with a diagnosis of schizophrenia has experienced persistent positive and negative symptoms despite trials of 3 different atypical antipsychotic medications at adequate doses for at least 6 weeks each. He has a history of poor adherence to oral medications, often due to perceived side effects and a lack of insight into his illness. His current regimen includes a second-generation antipsychotic, but his functional impairment remains significant, and he experiences auditory hallucinations intermittently. What is the most appropriate next step in managing this patient's treatment resistance? Option A. Immediately initiate clozapine therapy given the patient's history of treatment resistance and poor adherence, without further diagnostic review or discussion of other options. Option B. Recommend immediate inpatient hospitalization for involuntary medication management to ensure adherence and symptom control. Option C. Conduct a comprehensive reevaluation of the diagnosis. Explore augmentation strategies with non-antipsychotic medications. Consider a trial of a different class of antipsychotic if not already attempted, and discuss the potential benefits and risks of clozapine with the patient and their family. Option D. Increase the dose of the current second-generation antipsychotic to the maximum tolerated level, assuming that higher doses will eventually yield a response. The correct answer is C. Conduct a comprehensive reevaluation of the diagnosis. Explore augmentation strategies with non-antipsychotic medications. Consider a trial of a different class of antipsychotic if not already attempted, and discuss the potential benefits and risks of clozapine with the patient and their family. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in psychiatric practice, managing treatment resistance in a patient with a severe mental illness, specifically treatment-resistant schizophrenia. The professional challenge lies in balancing the need for effective symptom management with the patient's autonomy, safety, and the potential for adverse effects from aggressive intervention. The patient's history of non-adherence and the severity of their symptoms necessitate a careful, multifaceted approach that considers both pharmacological and non-pharmacological strategies, while adhering to strict legal and ethical guidelines regarding involuntary treatment and patient rights. Correct approach analysis. The correct approach prioritizes a comprehensive, evidence-based strategy that involves a thorough reevaluation of the diagnosis and treatment history, consultation with specialists, and a patient-centered discussion of all available options, including augmentation strategies and alternative medications. This aligns with best professional practice by ensuring that all avenues are explored before considering more restrictive measures. The American Board of Psychiatry and Neurology, ABPN, emphasizes the importance of continuous learning and the application of current scientific knowledge in patient care. This approach reflects a commitment to evidence-based medicine and a thorough diagnostic process, which are fundamental to responsible psychiatric practice. Furthermore, it respects patient autonomy by involving them in the decision-making process, even when facing significant challenges. Incorrect approaches analysis. One incorrect approach involves immediately escalating to clozapine without a thorough reevaluation or discussion of less restrictive alternatives. This bypasses crucial steps in responsible treatment escalation and may not be the most appropriate or effective next step, potentially leading to unnecessary side effects or patient distress. Ethically, this could be seen as a failure to explore all reasonable options and to adequately involve the patient in treatment planning. Another incorrect approach is to solely focus on increasing the dosage of the current antipsychotic medication. While dose adjustments are a standard part of treatment, in treatment-resistant cases, this can lead to increased risk of side effects without a proportional increase in efficacy. This approach may also indicate a failure to consider the broader spectrum of treatment options available for refractory symptoms, potentially violating the ABPN expectation of comprehensive patient care. A third incorrect approach is to recommend immediate hospitalization for involuntary medication management without first exhausting all outpatient treatment options and engaging in a thorough discussion with the patient and their family, if appropriate and consented to. While involuntary treatment is a necessary tool in specific circumstances, it is a measure of last resort and requires strict adherence to legal and ethical protocols, including demonstrating that less restrictive alternatives have failed or are not feasible. This approach could represent a premature resort to coercive measures, potentially undermining the therapeutic alliance and patient trust. Professional reasoning. Professionals facing such a scenario should employ a systematic decision-making process. This begins with a thorough review of the patient's history, current symptoms, and previous treatment responses. Next, a comprehensive differential diagnosis should be considered to rule out other contributing factors. Consultation with colleagues or specialists, particularly in complex cases of treatment resistance, is a hallmark of best practice. Open and honest communication with the patient about their condition, treatment options, potential benefits, risks, and alternatives is paramount. This shared decision-making process, guided by evidence-based guidelines and ethical principles, ensures that the chosen treatment strategy is both clinically sound and respectful of the patient's rights and preferences. Question 18. The investigation demonstrates a patient presenting with reported auditory hallucinations and a pervasive lack of motivation and emotional expression. Which approach best characterizes the comprehensive evaluation of these symptoms? Option A. Prioritizing the objective observation of the patient's lack of motivation and emotional expression, disregarding the reported hallucinations as potentially unreliable. Option B. Documenting the patient's self-reported hallucinations and observing for observable signs of avolition and blunted affect during the interview. Option C. Relying exclusively on collateral information from family members to confirm the presence and severity of both reported hallucinations and lack of motivation. Option D. Focusing solely on the patient's description of auditory hallucinations, assuming the lack of motivation is a secondary consequence. The correct answer is B. documenting the patient's self-reported hallucinations and observing for observable signs of avolition and blunted affect during the interview. Explanation. This scenario presents a common challenge in psychiatric assessment, differentiating between the subjective experience of a patient and objective observable behaviors, particularly when evaluating positive and negative symptoms of psychosis. The professional challenge lies in accurately capturing the nuances of the patient's presentation to inform diagnosis and treatment, while adhering to best practices in psychiatric evaluation. The correct approach represents best professional practice because it employs a comprehensive, multimodal assessment strategy. This includes direct observation of behavior, detailed patient self-report, and collateral information from reliable sources. This thoroughness ensures a balanced perspective, mitigating the risk of bias from any single source, and allowing for more accurate identification and characterization of both positive symptoms, e.g., hallucinations, delusions, and negative symptoms, e.g., avolition, alogia, and hedonia. This aligns with established clinical guidelines for the assessment of psychotic disorders, emphasizing the importance of a holistic evaluation. An incorrect approach that relies solely on patient self-report without objective behavioral observation would be professionally unacceptable. This failure stems from the potential for subjective distortions in reporting, especially in individuals experiencing altered states of consciousness or thought disorder. It neglects the ethical imperative to conduct a thorough and objective assessment, potentially leading to misdiagnosis and inappropriate treatment. Another incorrect approach that focuses exclusively on observable behaviors, while disregarding the patient's subjective experience, would also be professionally unacceptable. This overlooks the crucial role of the patient's internal world in understanding their illness. Ethically, it fails to respect the patient's autonomy and their right to be heard. Clinically, it can lead to an incomplete picture, missing subtle but significant symptoms that only the patient can report. A third incorrect approach that prioritizes a single diagnostic criterion without considering the broader symptom profile would be professionally unsound. This narrow focus can lead to a superficial understanding of the patient's condition, failing to capture the complexity of psychotic presentations, which often involve a constellation of both positive and negative symptoms. This approach is ethically problematic as it may result in an inadequate treatment plan that does not address the full spectrum of the patient's needs. The professional decision-making process for similar situations should involve a systematic approach. First, gathering information from multiple sources, patient, family, medical records. Second, observing the patient's behavior and affect directly. Third, actively listening to and validating the patient's subjective experiences. And fourth, synthesizing all gathered information to form a comprehensive diagnostic impression and treatment plan. This iterative process ensures that the assessment is both accurate and patient-centered. Question 19. Process analysis reveals that a patient presents with a history of fluctuating moods, periods of elevated energy, and decreased need for sleep, interspersed with episodes of profound sadness and anhedonia. The patient expresses a desire for treatment, but is hesitant about starting medication due to past negative experiences with side effects. The physician must determine the most appropriate initial management strategy. Which of the following represents the most ethically and clinically sound approach? Option A. Initiate a mood-stabilizing medication immediately, prioritizing rapid symptom control based on the most common treatment guidelines for bipolar disorder. Option B. Advise the patient to manage their symptoms through lifestyle changes alone, given their reluctance towards medication. Option C. Prescribe an antidepressant without a mood stabilizer, as the patient's primary complaint appears to be depressive symptoms. Option D. Conduct a thorough diagnostic assessment, including a detailed history, mental status examination, and exploration of the patient's concerns and preferences, before collaboratively developing a personalized treatment plan that may include psychotherapy and/or pharmacotherapy. Correct answer is A. Initiate a mood-stabilizing medication immediately, prioritizing rapid symptom control based on the most common treatment guidelines for bipolar disorder. Explanation. Scenario analysis. This scenario presents a common clinical challenge in managing bipolar disorder, balancing the need for mood stabilization with the potential for adverse effects and patient adherence. The physician must navigate complex diagnostic consideration, treatment options, and patient-specific factors, all within the ethical and regulatory framework governing psychiatric practice. The implementation challenge lies in translating evidence-based guidelines into personalized care while ensuring patient safety and informed consent. Correct approach analysis. The correct approach emphasizes a comprehensive, individualized assessment and a collaborative treatment planning process. This aligns with best professional practice by prioritizing patient well-being, autonomy, and adherence. It involves a thorough evaluation of the patient's history, symptom severity, comorbidities, and previous treatment responses. The physician's role is to educate the patient about treatment options, including their risks and benefits, and to involve the patient in shared decision-making. This approach respects the patient's right to self-determination and fosters a therapeutic alliance, which is crucial for long-term management of chronic conditions like bipolar disorder. Adherence to established clinical guidelines for bipolar disorder management, such as those from the American Psychiatric Association, is implicitly expected. Incorrect approaches analysis. One incorrect approach might involve initiating a medication without a thorough diagnostic workup or discussion of alternatives. This fails to uphold the ethical principle of beneficence by potentially exposing the patient to unnecessary risks or ineffective treatment. It also violates the principle of autonomy by not adequately informing the patient and involving them in the decision-making process. Regulatory frameworks emphasize the importance of informed consent and evidence-based practice, which this approach neglects. Another incorrect approach could be to solely rely on patient self-report without objective assessment or consideration of collateral information, especially if the patient's insight is impaired due to their illness. This risks misdiagnosis or inadequate treatment, potentially leading to patient harm. Ethical guidelines mandate a thorough and objective evaluation to ensure accurate diagnosis and appropriate care. A third incorrect approach might be to dismiss patient concerns about medication side effects without adequate investigation or adjustment of the treatment plan. This can lead to poor adherence, treatment failure, and patient dissatisfaction, undermining the therapeutic relationship and potentially violating the duty of care. Professionals are ethically and regulatorily obligated to address patient concerns and adjust treatment as needed. Professional reasoning. Professionals should approach such cases by first conducting a comprehensive diagnostic evaluation, considering differential diagnoses and ruling out other potential causes of mood instability. This should be followed by a detailed discussion with the patient about their symptoms, treatment goals, and available options, including pharmacotherapy, psychotherapy, and lifestyle modifications. Shared decision-making is paramount, ensuring the patient understands the rationale for treatment recommendations, potential benefits, and risks. Regular monitoring and reassessment are essential to evaluate treatment efficacy, manage side effects, and adapt the treatment plan as needed, always in collaboration with the patient. This systematic, patient-centered approach ensures adherence to ethical principles and regulatory requirements for quality patient care. Question 20. Performance analysis shows that a 45-year-old patient with a history of opioid use disorder presents requesting immediate detoxification. The patient expresses a strong preference for a short-term inpatient detoxification program, stating they just want to get it over with. The patient denies any current suicidal ideation, but reports significant social stressors including job loss and strained family relationships. The clinician is considering the most appropriate initial step in managing this patient's substance use disorder. Option A. Immediately admit the patient to an inpatient detoxification unit as requested, prioritizing rapid symptom relief. Option B. Refer the patient directly to an outpatient rehabilitation program, as inpatient detoxification alone is often insufficient for long-term recovery. Option C. Recommend a harm reduction approach focusing on needle exchange and overdose prevention education, as the patient's social stressors may indicate a lower likelihood of sustained abstinence. Option D. Initiate a comprehensive biopsychosocial assessment to evaluate the patient's readiness for change, co-occurring mental health conditions, and social support system before determining the most appropriate treatment modality. Correct answer is D. Initiate a comprehensive biopsychosocial assessment to evaluate the patient's readiness for change, co-occurring mental health conditions, and social support system before determining the most appropriate treatment modality. Explanation. This scenario presents a professionally challenging situation because it requires balancing patient autonomy with the clinician's duty of care, particularly when dealing with substance use disorders. The patient's expressed desire for a specific treatment modality, coupled with potential underlying factors influencing their decision-making, necessitates a thorough risk assessment that considers both immediate safety and long-term well-being. The American Board of Psychiatry and Neurology, APN guidelines emphasize evidence-based practice and patient-centered care, which means understanding the nuances of each treatment modality and tailoring the approach to the individual's needs and circumstances. Correct approach represents best professional practice because it prioritizes a comprehensive risk assessment before committing to a specific treatment. This aligns with APN emphasis on individualized care and ethical considerations in managing substance use disorders. A thorough assessment allows the clinician to identify potential contraindications, co-occurring conditions, and the patient's readiness for change, thereby ensuring the chosen modality is safe, effective, and aligned with the patient's overall health goals. This approach upholds the ethical principle of beneficence by acting in the patient's best interest and non-maleficence by avoiding potentially harmful interventions. An incorrect approach that solely focuses on immediate detoxification without a comprehensive risk assessment fails to address the underlying complexities of addiction and may lead to relapse or other adverse outcomes. This could be considered a regulatory failure if it deviates from established best practices for substance use disorder treatment, which mandate a holistic evaluation. An approach that dismisses the patient's expressed preference for rehabilitation without adequate justification, or conversely, blindly adheres to it without considering potential risks, also represents an ethical failure. It neglects the principle of shared decision-making and could lead to a treatment plan that is not optimally suited to the patient's recovery journey, potentially violating the duty to provide competent care. The professional decision-making process for similar situations should involve a systematic evaluation. First, conduct a thorough biopsychosocial assessment, including a detailed substance use history, mental health status, physical health, and social support system. Second, engage in open and empathetic communication with the patient to understand their goals, preferences, and perceived barriers to treatment. Third, educate the patient about the risks and benefits of all available treatment modalities, including detoxification, rehabilitation, and harm reduction strategies, in the context of their individual circumstances. Fourth, collaboratively develop a treatment plan that is evidence-based, patient-centered, and addresses the identified risks and needs. Finally, establish a plan for ongoing monitoring and adjustment of the treatment as the patient progresses.